So hi everyone, thanks and welcome to our Research Connect series. I am Amal Trigui, CDTRP trainee in CDTRP since 2021, and I will be facilitating today's webinar. So I am, just to introduce myself quickly, I am a PhD student in nutrition at University of Montreal, and I'm working with Dr. Chantal Bemer and Dr. Christopher Rose, and our research project are about malnutrition and sarcopenia before and after liver transplantation. So first, I would like to acknowledge that the CDTRP is hosted by the University of Alberta, which is located at Treaty 6 territory, a traditional gathering place for diverse indigenous people, including the Cree, Blackfoot, Métis, Nakatusu, Iroquois, Dean, Ojibwe, Saulteaux, Anishinaabe, Inuit, and many others whose histories, language, and culture continue to influence our vibrant community. So I encourage you to write your land acknowledgement in the chat box. And we would like also to acknowledge Astellas Takedi, AstraZeneca. Without whose generous support, we could not host these sessions. The CDTRP also relies on the help of our community. Your gift ensures we can focus on delivering our mission of supporting excellence in donation and transplantation research. So there will be a link in the chat box for those who are interested. And before we dive into the main content, I will pass it over to Erica for some generous CDTRP updates.
Thank you, Amal. I have two save the date announcements today. The first one is going to be for our PFB forum. This year's Patient, Family, and Donor Research Forum will be held virtually on June 8th and 9th. Registration is free and it can be done through our website. The link to register will be in the chat. And if you have any questions on this matter, feel free to message me or Manuel. Secondly, hot off the press, it's me attempting to do a drum roll. I am pleased to announce the dates for our location for our 10th annual scientific meeting. This year's ASM will be held in a hybrid format and with the in-person component in Montreal, Quebec on December 5th and 7th. We are delighted to announce that this year's co-chairs are Doctors Siba Haykal and Vanessa Silva E. Silva. We are currently accepting applications for program submissions from session ideas from researchers, oral presentations for a trainee competition. And this year, the education platform is hosting a pre-peer review workshop to help trainees and researchers perfect their manuscript before publication. All information, including submission links, will be found on our website, and I will be posting a link in the chat. That's all for me. Back to you.
Thank you, Erica. So before I introduce the speaker, I have a few housekeeping notes. Today's session is recorded and posted on the CDTRP website and YouTube channel. During the presentation, we encourage you to keep your cameras on, but we kindly request that to keep your mics off, please. And if you have any questions, comment, don't hesitate to raise your hand with the raise hand button. So today I am pleased to introduce our presenter, Dr. Sonny Dhanani. Dr. Dhanani is the Chief of Pediatric Intensive Care Unit at the Children's Hospital at Eastern Ontario, CHEO, and an Associate Professor at the University of Ottawa. He is currently the Chair of Canadian Donation Physician Network, Chair of Canadian Blood Services National Deceased Donation Advisory Committee, and steering member of the Health Canadians Organ Donation and Transplantation Collaborative. Dr. Dhanani is an Associate Director for Donation Research of the Canadian Donation and Transplant Research Program. His area of focus is leading international research on practices and standards for determining death after cardiac arrest for donation purposes. And we are very excited today to have you with us. I will hand it over to you now.
Thank you so much, Amal. Thank you, Erica. And thanks everyone for joining. It's a real pleasure actually to see so many names and faces on the board. So I hope that I can present something that's interesting to you and an opportunity for us to ask questions and learn from each other after. I think there'll be lots of time. I myself am speaking to you from Ottawa, so I'm on the Anishinaabe and Algonquin territories, and thoughtful of us all going through that journey together. I'm going to share my screen. Give me a second and I'll confirm with my team. How's that look, team? Amal?
Yes, perfect.
Very good, thank you. It says March 2023, it's obviously May. Yeah, so you can choose to trust me or not now. I'm not starting. Very good. I think most of this audience seems to me, when I look at the names, pretty familiar with donation practices in Canada and DCD, but we're going to review some of the barriers that I think about quite a bit, and then look at some of the research that we've been doing. And in fact, a lot of people on this call have helped me develop. And so I'm quite proud to present really on behalf of many of the people on this call. I think Amal actually listed some of my disclosures. Two things that I'd want to note: that I do get a small stipend from Trillium Gift of Life as a hospital donation physician here at CHEO. And I do share in a patent related to Donation Advisor, but no commercial entity at this point. We'll start with a bit of story. I don't think Dawn's on this call, but Dawn is a patient, family donor partner that we've been working with for a number of years on Donation Advisor and other topics. I relate to Dawn. We're probably about the same age, maybe he's a little older. He's got kids, he's adopted some of them. He loves playing hockey, he's a goalie. I don't know who's better, me or him, but one day while he's playing with his local team pickup, a breakaway is coming down and he apparently makes a save, but doesn't remember it. I remember I was trying to say, please tell the children as he passes out, but then I was gone, Brinklow says, his eyes filling with tears. In my mind, I was still awake and saying, please tell the children I love them. And I remember this wave of regret that came over me as I was fading. Don on the ice was resuscitated by his teammates, who just happened to be firefighters on a cold ice for 45 minutes, got to hospital, and over the next couple of weeks ended up needing a heart transplant. This is how he looks today. Pretty damn good, I must say. An inspiration, and stories like this from Don and his wife Patty and others like Heather Talbot, who I think is on the call, inspire us all to move forward and keep going. We believe in organ donation and transplant, but it's a complex system. It's hard to be a donor, and i.e. it's hard to get a transplant. You have to die within an ICU under very specific circumstances where your organs are good enough to be transplanted. There's strict criteria. Your family has to get consent. You have to die in a certain way in a certain time frame, either from neurologic criteria or circulatory criteria or heart criteria. Declare dead officially and permanently, then mobilize surgical teams and get those organs safely to be transplanted at another site. A really, really tough proposition. And as a result, it's a rare event. In Canada, there's still over 4,000 people waiting on the transplant list. Oh my God, that's my sister calling. A lot of people die on that list every year. These technically should be called preventable or missed deaths. Yet there are only about 700 donors across the entire country of about 40 million people. So each potential donor is a gift, but it's rare. So we look to maximize that. We're still struggling to keep up with our international counterparts, though we've done a lot. We've done a lot at Canadian Blood Services. We've done a lot at organ donation organizations across the country. And we've done a lot here at CDTRP to try to make these numbers better. One transplant for life, of course. But you can see the red bar in Canada. We still are in the middle of the pack. It's rare because it's a complex situation. There's two ways to become there's three ways to become a donor. One is a living donor, and we won't talk about that, but to be a deceased donor, you either have to fulfill neurologic criteria of death or work through a pathway of no hope for recovery and discussions about withdrawing life-sustaining therapies and then death by circulatory criteria. I've tended to focus on both areas of determination of death because it's been complicated. And in my opinion, we need to build trust. For example, when we look at donation after circulatory death, this idea of subjectively trying to make decisions of end of life cloudy or make our decision to go forward with organ donation a little bit unclear. When does that discussion happen? How do we make sure that we're not impacting the decision to withdraw life-sustaining therapies? And that how do we keep that separate so that there's no conflict of interest for our healthcare teams, but also even for family members? How exactly do we withdraw life-sustaining therapies in the event that we want to actually have death occur in a timely fashion while not expediting death? Because in fact, that at this point isn't current standard of practice. And how do we actually determine death? Because we need to make sure death occurs before organ donation. There's been a lot of controversy here. And in fact, CBC has taken in, the BBC has taken in stories that inflame what might be happening or actually what might not be happening. And so really this is about trust. We needed to investigate how death determination occurs and create better standards of practice so that we can move forward with organ donation, especially DCD, in a defined way so that we can build trust. And again, that's with the patients, with the public, with families, but as importantly, with our healthcare team. Our fundamental principle with death determination is the dead donor rule. Many of you heard this, but one must be dead before the act of donation, the recovery of organs actually occurs. And the object of donation, or the process of donation, can actually cause or expedite death. These are two fundamental principles that have been in place to protect patients. And in fact, protect the healthcare system from moving too fast. How do we define death to make sure the dead donor rule is in place? That in Canada has been fairly nebulous. In quotations, death must be determined by two physicians by accepted medical practice. The physicians must be present and must have adequate credentials. It's pretty vague, actually. So when we look at trust, we want to make sure we're operating within these functions, but we could probably make these standards a bit better. Trying to answer what accepted medical practice is. In fact, this is relatively hot off the press to be released this week or next, is the new brain-based definition of defining death determination after both circulation and neurologic function stops. These are unique for Canada. We've had individual documents since 2003, 2006 on how we should practice, but 15 years later, especially as organ donation increases in Canada, that this document is going to be super helpful. The document itself is 30 pages long, but it comes along with, I think, almost 30 scientific articles backing up the consensus that was put together. And really the fundamental principle here is that death, for all purposes, is neither neurologic or circulatory on its own. It is brain death, that no function of the brain is what death is about. And there's two ways to determine death, either by neurologic criteria or circulatory criteria. Now, I think I have time to show you this short video. I'd love to get your feedback on it at the end. Give me a second. it should start playing. And it's only a minute long, guys.
The brain keeps us alive by
Sonny?
the center of the human body.
Yes.
Sonny, you have to do a new share with your web
Okay,
page.
thank you. Thank
No
you.
worries.
Give me a second. Give me a second. Sorry, okay, new share. How do I do that? New share. Now do you see it?
Yes, we do.
Okay.
The brain keeps us alive by acting as the command center of the human body. It lets us think, feel, move, breathe, and interact with the world. The brain needs to send signals to the lungs to breathe and collect oxygen. Blood carries oxygen to the whole body. Oxygen fuels all parts of the body and brain. Death occurs when brain function ends. There are 3 ways this can happen. First, the brain may have a serious injury and shut down. The injured brain may swell, so blood with oxygen cannot flow into the brain. Second, the heart may stop beating. If the heart doesn't pump blood to the brain, then the brain doesn't get oxygen. Third, the lungs may stop breathing. If the lungs don't collect oxygen, the heart stops beating. Then the heart cannot send blood with oxygen to the brain. In all 3 cases, the brain tissue dies without oxygen. This is permanent. Doctors can use machines to keep the heart and lungs working after death, but they cannot restart brain function. Because the brain keeps us alive, the end of brain function is death.
Okay, thank you. Now I think I have to reshare if I'm correct.
There you go.
Yeah. Oh no. No, I'm way off. Oh, that was a bit harder than I wanted it to be. Can you see that now, guys? The definition of death at the top?
Got it.
All
Yeah,
good.
thank you. So, you know, this was a group of many physicians, nurses, public stakeholders, family and patients, ethicists. Super important to bring a group together. But I think what's different about this guidelines and consensus statement is there was a heavy commitment to making sure that it was based on science, where science existed. We reviewed things like the definition of death from the brain-based concept. There was legal considerations and how it impacted the Canadian Charter of Rights and Freedoms. There was provincial aspects and ethical considerations. How do we mitigate and manage conflict when we create this new definition? And most important, the stakeholder engagement. But as I say, it was based on science, and my focus on the circulatory criteria is that we use the science that exists, and then we created a framework of what needed to happen for future investigations. This study that we published in the New England Journal of Medicine was one of the first studies put together by CDTRP almost, 10 years ago, as we celebrate the anniversary, that really made a big impact on these new guidelines. For some of you to refresh, we looked at over 600 patients dying in ICUs to really look at the natural history of death and dying from a physiologic perspective. And our whole motive was to really explain what happened at the time of actual determination of death, to make sure death was permanent, and how we could incorporate that to build trust for future guidelines when it came to organ recovery and make sure the dead donor rule was intact. This is the blood pressure in red and the heart rate in green. You can see it stops. There's some artifact there. And then all of a sudden, in some patients, we saw it restart it on its own without actually any resuscitation. This happened in about 14% of our patients, so 1 in 8. We used studies like this and looked at other case reports and other observational studies to really try to ask questions to help these guidelines. In this case, how long should we wait after the heart stops before confirming death? So these guidelines are quite different. And when we looked at neurologic criteria, we did the same thing. What did we learn when we looked at these investigations and used a very strict criteria to bring this evidence together? Well, for circulatory criteria, that actually we acknowledge that transient unassisted resumption of cardiac activity does occur in normal processes after withdrawal of life-sustaining therapy, and that we shouldn't be afraid of it or not expecting it. We should counsel families that this may occur, and that we should wait for this activity to stop. How long should we wait? We should wait for 5 minutes. And because these events do occur, we want to make sure that we're monitoring properly and using arterial blood pressure monitors and using set criteria. What means a resumption in our eyes at the bedside. We're hoping these will be firm criteria as we develop more evidence, but really the goal is that we think this helps build trust in our donation processes. And that's the overarching goal of the new guidelines. But we have more questions. As I mentioned, we're now not just thinking about circulation stopping for the sake of the heart stopping. Under our new criteria, that what's really important is the brain function stopping. And so we're carrying on our D-part study and looking at new part. New part is led by Murat and Tennille in London, Ontario, with a number of collaborators across the country that looking at the cessation of circulation, but then really trying to monitor what happens in the brain and taking a holistic approach, not just looking at the physiology, but looking at law, ethics, policy, and social sciences to try to figure out when the brain function stops. This might look overwhelming. We've actually got a patient in the middle under consent and ethics review with a number of monitors looking at oxygenation of the brain, blood flow of the brain, metabolics of the brain, electrical activity of the brain during the dying process in an ICU. This is hard to look at, but we're very thankful for the families that are participating in here because it's advancing our knowledge, and not just knowledge for the sake of academics, but to actually move us into making better guidelines that we trust and that we can help families engage. Our initial findings here show that there was no brain activity almost 2 minutes prior to circulatory arrest. We need further evidence because this was actually just a small number of patients, and both a group in London and a group in Vancouver is now looking into this. This is world-leading science that's happening here in Canada and with the participation of CDTRP. Why it matters? Why are we looking at these grim findings? Well, the determination in clinical practice is super important to clarify that death is permanent, and it really is related to what's happening in the brain, that we promote consistency in practice across the country, that once someone's dead, that we can be more comfortable with post-mortem interventions. That's usually, in our context, taking organs out, but in the future, it may be perfusing organs even in the body. How do we address legal and ethical challenges and minimizing the risks associated with getting donation wrong? And as I mentioned, I think a lot of times, really about trust and integrity. Now, when we looked at D-part, we were really looking at the science of the determination of death specifically. But in fact, what we realized is that for the first time, we had involved well over 600 patients and watched them pass away, watched them die. And there was so much information, and we didn't want to just take one thing from these families and these patients who were part of the study. There was more to see. And in fact, we recognized that we were able to take the data coming from these patients prior to death and during the dying process, the heart rate and blood pressure, that actually could help us predict who might be a better donor. Let me tell you a little bit about that innovation and the work we're doing now. I've already mentioned that donation is a rare event, even when consent occurs. And as a result, transplant is really rare. And one of the key factors in donation after circulatory death is timing of death. Once the heart rate slows down and the blood pressure softens and the oxygen levels decrease, which happens during the dying process after withdrawal of the life-sustaining therapies like a ventilator or like blood pressure medications like epinephrine, not only is the patient dying, but the organs are dying. And for those organs then to be recovered and then transplanted in another person was why this sort of organ donation didn't occur before 2006. It was only the mechanisms of increasing surgery and increasing reperfusion techniques on those organs that we were able to do this type of donation and transplant. But in fact, we still have a window of about 2 hours. The kidneys are really robust, even without oxygen and blood flow. But after 2 hours, it's a struggle. Same with the lungs. Definitely the liver really is very fragile after about 30 minutes without good blood flow. So in fact, in a lot of situations, DCD isn't even offered to patients and their families when the timing of death is unclear, or the team feels that death will occur after 2 hours from the time of withdrawal. Or it's attempted, and in fact, the individual doesn't die in time and no organs are recovered. That's usually with a transplant team waiting in the wings in the OR and then told to stand down when that individual doesn't die because it's unclear if those organs would be transplantable. In fact, this happens about 30% of the time when we reviewed this in Ontario. That's a huge cost to the system. Now, obviously, we think about financial costs of flying a transplant team into that situation and then walking away without organs. But in fact, I think the heavy burden is on the family. This is a family that was motivated to donate. This is a healthcare team and organ donation team, including coordinators, that was motivated to try to help this family. Not only is that patient and family member passing away or dying, but now they're also not going to be an organ donor. This is hard on the families. I think the inability to predict which patients will be a donor and which organs are suitable for transplant is something we can do better. And that's what we realized, that though that wasn't in our initial question, predicting the time may be more important than what we initially found. That's where our new tool, the Donation Advisor, which is a clinical decision support tool, came around. Working with Andrew Seeley, who's an intensivist and thoracic surgeon at the Ottawa Hospital here, and a leader in prediction science and decision support tools. Our hypothesis was when we looked at heart rates and blood pressure in a dying patient, whether they were going to be a donor or not, that we recognized that changes in variability of that heart rate, i.e. when it wasn't variable and when the blood pressure was very stable, actually predicted a rapid death after withdrawal. We thought that if we examine this variability, that we might be able to predict in donors who might die within that 2-hour window, maybe even within that 30-minute window. Now, this takes a lot of work behind the scenes, looking at patient waveforms in real time, taking out artifact, creating models, including AI and machine learning, analyzing them for complexity and variability, and then creating a predicted model. This is where our patent comes in, and very thankful for biomedical engineers like Nathan Scales and Andrew Seeley's team. Here's one graph I won't go into the detail, but we were able to separate patients into 3 separate cohorts, just based on the variability of their heart rate and blood pressure and saturations prior to death, into groups having a low, medium, or high likelihood of dying within a 2-hour window. We think this is separate from all the other clinical variables that people have used in the past. No tools have been good enough. In fact, there have been lots of tools being tried, but until now, I think we've never had something more objective. So we were very excited about this. Not only did we realize we could look at heart rates and variability before death, we realized that actually during the process of dying, that we could use the same measures to try to figure out what was happening to those organs. The term ischemia really relates to blood flow and oxygen delivery to an organ. Right now, transplant teams use time and time alone. If it's 2 hours, no matter what's going on with blood pressure and oxygen levels, 2 hours is 2 hours, and they will stand down. But we were able to now create a model where in real time we could evaluate how much blood flow and how much oxygen was probably getting to these organs. And I'll show you some pictures of that. So we think we can turn just time as a marker into what we call functional ischemic time. What's actually happening in those 2 hours? From our standpoint, we've got a laptop at the bedside that hooks into the monitors, so very non-invasive in technical terms, allowing the dying process to occur as would happen in a potential donation, collecting lots of data that's probably already collected, but we think we could put all this data together, including our tool. We've got a big team that tends to keep growing. Thank you to all our steering committees and other people on the call. I'll mention Natasha's work in a second. So our donation advisor is really a clinical tool that the clinicians, meaning the donation physicians, the organ donation organizations, as well as the transplant teams, trying to see if the organ is going to be a success for transplant. Prior to withdrawal of life-sustaining therapies, we think we can optimize and predict success. We can help standardize the assessment of a potential donor altogether. And what we're hoping is this information might actually help the families. Family maybe consent, but even if they're consenting already, to help with communication, to give them a realistic expectation of whether their loved one is going to be a donor or not. We don't want to impact whether they actually go forward. I think that's a decision that's bigger than that. But when they do go forward, we want to give them as much information as possible of whether this is actually going to happen. And of course, after the withdrawal, and we're giving ischemic time information to the transplant teams, we want to better objectively characterize that ischemia. And our hope is that actually teams stick with it, that maybe we'll push past the 2-hour boundaries. Maybe they won't stand down. Maybe those organs will be placed into transplant recipients that may not have received organs before. So we want to see if it's acceptable, efficient, and effective. This is the timeline in blue. There's a decision to withdraw life-sustaining therapies. The organ donation organization identifies an eligible donor. They're approached and consented, and that's when our tool comes into play. Oops. We give the teams a prediction of time to death, an overall probability of dying within 30 minutes, an hour, or 2 hours. We have now 3 ways of defining this. One is what I've described, the variability, heart rate and blood pressure. That's the novel part of this, using machine learning. We then go back to a clinician model, to clinical model, looking at the body mass index, or the size of the patient, the neurologic status prior to death, how many organ preserving medications are on, like epinephrine, and what settings they are on the ventilator, for example. And then we also ask the bedside physicians and nurses And we put all that together for the first time to create a very robust tool that we're now testing. After withdrawal is started, we then look at the ischemia. We look at SBP, which is the blood pressure, the MAP, which is the average blood pressure, and the SpO2, which is the saturations at any given time in 5-minute intervals. And this may be hard for us to understand, but a transplant surgeon is looking for this. You can imagine that if two patients die within 2 hours, that they can die in 2 different ways. For 1 hour and 55 minutes, the blood pressure is really good and the saturations are really good. And really that falls in the last 5 minutes before death is determined. Versus right at minute 5, the oxygen levels drop and the blood pressure drops and then lasts for 1 hour and 55 minutes. Those 2 scenarios, though 2 hours, are very different. And we're now for the first time outlining that in detail in real time to the transplant surgeons. We've now started this in 7 ICUs as a pilot, mostly at the Ottawa Hospital, but other hospitals now starting in Ontario to see whether it's actually feasible to use the donation advisor, whether the donation teams like it, whether the transplant teams like it. We haven't yet brought it to the families. We found that we're able to collect the data. We're actually able to collect the predictions from the clinicians and collect the waveforms and put them all into our donation advisor to create the predictions and the evaluations of ischemia. We're now seeing how we can identify how those organs did so that we can correlate our predictions and ischemic evaluations to actually organ outcomes. We've realized that this is a tough thing to do. And so we've used a team at Ottawa Hospital in evaluation science. And Natasha, I saw her on the call, has done many, many interviews of clinicians who have used the tool to try to hone down and find the balance of what's important, at the same time giving a tool that's useful and concise. Our tool was almost 11 pages to start, and this summarizes hours of work from our team. But really, we recognized that we actually needed 2 reports, one for the donation team that focused on things that were important for them prior to donation, and one for the transplant team that really was looking at what those organs and the ischemia were rather than the withdrawal data to start. We've taken out a lot of data that we thought was important, but wasn't important to the people at the bedside making decisions. And so we reduced the length of the reports almost by half, so it's only about 5 or 6 pages. We made technical improvements and validated the model so that it's getting better and better with every patient that we enroll. We've added clinical features to make the variability science better. And our software modules now are easier to go into monitors of all hospitals rather than just a few. There's so many bugs involved here, and our technical teams have been working throughout the year as we had Health Canada funding that ends this year. We've got a nice website, donationadvisor.ca, that tells our story and looks through what we've done so far. So I recommend you go to there. We've been funded by Health Canada over the last 3 years as part of the collaborative. But really, CDTRP started this research. We have the group at Ottawa Hospital and the DAL Informatics Group, the OHRI, the CHEO Research Institute, and of course, TGLN has supported us. Very exciting in making their processes better. So it's been a very collaborative effort. We've got a lot of work to do before this becomes a reality. We've gone through our feasibility, which ends now, and we're ending our interviews, and we hope we'll have our final kind of donation advisor tool by April. And then I noticed that was 2 days ago. So we're almost there. By early or late spring, I think we will have our final DA tool that we'd like to take to the next level. And what that next level is really putting this into practice. We know we can do it and collect the information and enroll patients. What we have to do is now use a format called a randomized controlled trial, where some patients who are dying and going forward for donation have access to our tool, meaning the family, the organ donation organization, and the transplant teams. And some of the patients don't. And then we want to go back and look at the family experience. We want to look at the clinical experience. How many organs were donated? How many organs were transplanted? Were some people not going forward for donation because of the information? Is their experience better? And we want to do an economic analysis to identify whether we're actually saving money or making better choices with our resources. I think for this to go forward, it's going to need some commercialization, but we are working through that with organizations like CDTRP and national networks to figure out how we do that and still focus on patients and families and donors as we go forward. Maybe one day, I think I saw David Hartel on the call. I always thank him for putting this together. It was a late night before a grant where David sent me this graphic. This is our hope that one day we get this on an iPad and it's an app and very clear for everybody involved what we're doing, predicting time to death, assessing the organs, and identifying ischemic time for transplant teams. A lot of people have helped support this, including the trials group, CDTRP, and Health Canada. I hope one day, we have donation advisor in practice. It's acceptable to families, that it's efficient for the system, and it's effective for donation and transplant systems. But I'd end in just reminding, as I always need to do, is that this is about patients and families. And this is a family that consented to donation but didn't get an opportunity. Nobody told us that he might not die in time. The doctor was so convinced that he was going to die within 15 minutes. I don't hold that against the doctor because I recognize that we're not so perfect and that we don't always get that right. But what didn't happen was an explanation. So when they extubated, the whole team was sitting outside. I kept looking at the clock. I cried. I kept saying, oh God, please take him and let his organs help somebody if I'm going to lose him. Anyways, when it was over, they couldn't take his organs, and I felt like I'd failed the world. This is such a heavy quote. And it's a heavy quote because I think we can make a difference. I think that if donation advisor is successful, we'll be able to take this quote and hopefully have it happen less and less. I remind you, donation and transplant rare event. That's why we're in this together, that the new guidelines and new innovation are going to build trust, and that scientific discovery through CDTRP is optimizing that. So I really want to thank you for your time. I hope I've been clear, and I'm happy to answer any questions or bring new topics of discussion. Thanks again for your time and listening. Thanks.
Thanks, Dr. Dhanani, for the excellent presentation. It was very clear and I learned a lot through all the slides. So thanks. I will now open the floor for any questions. Please don't hesitate to raise the hand and send questions also in the chat box. I will be happy to read them. Maybe I can start to read some comment that Natasha Hudek sent it. So she said, thanks, Sonny, always fascinating to see how our small contribution fit into the large project. We have also a comment from Chantal Bemer that she said, thanks, Dr. Dhanani, for this excellent talk, very inspiring. And I have a question from William. Clement, please go and ask your question.
Thank you very much for the presentation. This is William Clement at CHEO, so we're not very far from where you are. I also work with TOH at thoracic surgery, and we do have a system that does something similar for patient follow-up after lung resection. So plenty of ideas, plenty of data, and forgive me if I jump straight into the science. I am a computer scientist by training, but I spent a good 20 years applying it in medicine. Yeah. Transplantation, lung transplantation, thoracic surgery, etc.
Excellent.
So I have a list of questions here.
Okay.
But what struck me the most with your final wrap up of the comment is that, step back from it a little bit. What you're looking at is the relationship between the definition of what's a better donor and the timing of death. So you're looking at predicting time to event, and you're looking for a structure that describes what a better donor is. And forgive my rather blunt approach to representing this. You're looking for what we call in mathematics a structural dependency, where you have a stream of data coming in. You see something here, something there, and something over there. Structurally together, they paint a picture that predicts the event. So what happens here is that maybe to the human trained eye, the physician or the medical team, they may not necessarily see that picture because there are too many parameters, but there is a combination or a permutation of these values so that you're able to predict both events in one shot. And if you're able to establish that kind of relationship, then you can use it as a one-sided relationship to be informed of the other. So for example, when is it the best time for me to achieve that maximized quality of donation? You open that time window, which means I can tell you if death does not occur between X and Y, then give up, walk away, go home, clean up, and wait for whenever it happens, right? There are many things you can do here. And on top of all that, defining what's better. What is a better donor, right? Now that's a bag full of problems, I do understand. And especially if you add the type of organ into it, then it goes nuts. And we haven't added patient history, potential rejection, blah, 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 blah. I'm not going to add too much into it. However, if you had some sort of a protocol that says, if you see this, if you see this, if you this minimum criteria for donation has been established, clinically speaking, scientifically speaking, you can now try to understand the relationship between the time of death and that particular protocol that you describe somehow. And of course, I'm hand waving here. And this is a structural dependency. This is stuff that's been done in mathematics at least 20 years ago that I know of it for 20 years. I'm sure it was done a little earlier. All you need is the correct stream of data. So it's mostly the data that you're collecting in that laptop sitting next to the equipment.
I know. William, excellent thoughts. I've just booked you in for like a 3-hour session tomorrow with the team, if that's okay. I hope you don't have any other grants or stuff.
I'll make time for it. I'll make time for it.
This is the evolution, as we start with simple answer, simplifying to get us moving, we're recognizing the potential of this. There are gaps, and variability is a gap. Transplant teams and what they take as a donor or an organ is so variable that we're struggling with our outcome data to try to link what would make a better donor. And so right now we're working in the context of where we are, meaning time and resources. But clearly, once we get moving and we break down some barriers about collecting the right information and implementing our tool into this environment, the sky's the limit on what we may be able to uncover in ways that you're doing this, where we take some of the actual clinician biases out of that and actually look at the numbers and the math. And we've already found that helpful, but we may take this to another level. Love it, but I'd love to have more conversation, especially with my smarter colleagues that can keep up with you. Right, William?
Absolutely. I'd be delighted because there's plenty of work that can be done once you have the data. So from our end, we need data. We're like enslaved by the data. No data, there's not much we can do.
Love it.
Cheers.
Caroline?
Thank you.
Hello, thank you. This was, I'm learning all the time, and of course, I'm not a physician and a medical person. I'm an anthropologist. So my question goes to the families and the ways in which, the timing, right? So you've got two types of time, and one is medical time and the urgency in order to procure organs at a specific time with cardiac death. And then you have what we have is cultural time, right? Time in which when death occurs, that it's often a very quiet time for families, a very reflective time, sitting with the person who's passed on. And so as I hear you speak, it's a lot about creating new meanings for death, right? So with cardiac death, in articulating to families a certain level of hopefulness and because at the end of the day, this is kind of in some ways, ghoulish in the sense that people are waiting for someone to die. And they're timing death, and it conjures up all kinds of images of people waiting around for you to die. And I think the quote is very telling, right? About the ways in which care is given to patients or patients' families, and the ways in which that expectation, because with that hopefulness comes an expectation that in their death will become this life of giving life to someone else and giving a gift to someone else. And that's really that metaphor of the gift of life has been so essential in organ transplant, but it is somewhat different around cardiac death. So as you've been doing this research, I'm very curious about different cultural groups, different ethnic groups, and the ways in which that kind of played out, and whether you see certain people, whether it's generational or whether it's cultural, whether it's gendered, having different opinions about this, and I guess to an extension of when we ask for that donation, then we're also saying you can never know where it goes. Right? You can never know where the hopefulness and where the new life that is the result of this ends up being. So that in itself must be difficult, I think, where people have to give, but they also have to let go. And there is no future for them in the context of which we're discussing, right?
So insightful. If I might just reflect, look at the two questions that came up. This is why I love being involved with, like, William's over here and, all about the numbers, and Caroline's over here talking about the people, right? But that's what's bringing us all together in this space. Not even just donation advisor, but like on this call. It's inspiring, and that's the benefit. I can't answer your question directly, Caroline, except that what we're developing is the right people to ask these questions, right? Like, as part of this space, we're mindful of how complex this is. As we're going to bring this into a sphere of engaging families, and so we've got Amy Sarti and his group and her group that have done a lot of work. We have, social scientists involved, so that as we go into, I think we just have to be so careful that, one, we're acknowledging the diversity of what we're trying to do here, and that there's so many different voices that we need to do this thoughtfully and slowly, so that it's meaningful and we can get the right outcome for, as we go forward. And again, if you have time, I'm gonna hook you up to 3 hours after William, so that we can continue the conversation, because I do think these are things that make this project so important, that we have so many different angles to be able to that we need to address to do this right, rather than breaking down trust. It's an opportunity for us to build trust in that area. I got Rink and then Nick.
We can have one more question maybe, or two, if the answer is so quick, because
yeah, okay.
we have only 3 minutes left.
Oh yeah.
I have a question in the chat, so I can read it quickly because it was the first one to be asked. So I know you suggest launching a RCT to evaluate the introduction of donation advisor, but when I hear you describe the tool and the application, I wonder if a pragmatic trial will be a better and more feasible strategy. And the question was from David Hartle.
Yeah, David, great question. David is a pragmatist, meaning, he just gets things done. We've debated quite a bit and moved towards an RCT. I think part of this may be the pragmatic approach really means that we're going to eventually have to try to commercialize this to make it useful to implement in all hospitals, because you can't do that from research forever. And to do that, we need the RCT, but we're struggling with that same question. We really want to make this impactful right away, but that's why we've discussed it there.
And
More
maybe
questions?
last question, maybe from Renk de Vries.
De Vries, yeah. Just a quick, I'm a heart transplant recipient, but I'm also an engineer. So I was going to try and look at the piece between William's sort of data set, because there's a data set, when you talk about outcomes, there's a data set on the recipient side as well. When we have our sort of social preparation meetings and all, they say, you're supposed to receive the heart. And, I kind of think, oh my God, all my engineering training hasn't trained me how to do this. What is this data? How do I receive this heart properly? There's a human part to that. There's an emotional part to that, as well as a technical part to that. How good of a recipient are you? So when we're talking about outcomes, there's a whole data set associated on the recipient side that should match up with the data set on the donor side. So I think that analysis, I think there's probably, again, well, there's always wider analyses we could do, but I think that's an important piece of it too. And so there's a technical part and an emotional part that are both kind of part of this, making sure that outcomes ultimately are, creating life through donation and transplantation. And I think so. Those are the ultimate outcomes. And again, I'm doing very well, as you had your pictures in the beginning of the presentation. And I think 10 years hence, I'm in excellent shape, and it is unbelievable how this happens. And so I think there's a wider application of your tool, maybe also on the other side, on the patient side. So that's
so important. And there is a lot of work there. We're working with Mama Sabat and others looking at, and there's a big grant from Michael Chasse in Quebec, looking at AI and other groups there. This is the space that we're going to start consolidating those teams as this develops forward. There's so much there. Thanks for that opportunity.
I see two more questions.
Do we have to stop?
It's really as you want, Dr. Dhanani. If you want to stay more, or you can't stay more, we can take more questions. But if you are
sure, I'm happy to stay for a few more minutes. I think
so,
I have a 2 o'clock call, but some of them are here anyway, so they'll understand. I can read Chelsea's. Obviously we're talking about controlled donation after circulatory death, but Chelsea's previous work that I'm familiar with is in uncontrolled donation. I think where our main focus would be for uncontrolled donation is the study I showed you, Newpart, really looking at circulatory arrest and resumption and its impact on neurologic function. I think it's going to be super important to make sure that once interventions, post-mortem interventions, are restarted as they do in uncontrolled DCD to kind of reperfuse organs, that the brain is not functioning during that time, and how we make sure that's true, because that then maintains our dead donor rule. So I think that's really important. And then from there, absolutely, we're going to be able to look at ischemic time, if there is any. Yeah, it's a great question.
Thanks.
Linda's saying recognizing the ethical separations between donation and transplantation. The advisor will be a solid scientific tool to support and facilitate important, timely conversations. Exactly. I think we've always, especially on the donation side, actually maintained a fairly hard line between transplant surgeons and their efforts to know more about the donor and the withdrawal process. And you're right, we're trying to create a space that links that. And in fact, you know, that's why we have two different tools now, one for the transplant teams and one for the donor teams, because some of the transplant teams didn't want to know some of the things that the donation teams wanted. They wanted to know whether the organs were fine, not whether the more the details of the patient dying. And so I think that was just highlights your comment there.
Yeah, I saw a hand from Nicolas Murphy. Yeah.
Thank you. Thanks for the talk. Just hearing the question about families and talking about the harms of unsuccessful donation for families had me thinking about the particular harms of unsuccessful donation in the context of pediatrics. And I'm wondering, I know you had a smaller sample of pediatric patients in D part, but I'm wondering whether you expect that this model would be generalizable to the pediatric context, or whether you see a completely different model being required given differences in
I think the
physiology.
model will work. We need to validate in a bigger cohort. And so we are walking down that path, though a little slowly because of COVID. And we have to engage hospitals that do have a lot of pediatric deaths, because our overall numbers are much, much less than what we quickly accumulated in the DPART study initially. So we got some work to do. I think that we'll be able to just prove that the pediatric cohort is the same as the adults and then be able to use our models. That's our hope. What we've realized is that for pediatrics, it may not be just about donors. It may be about end of life and withdrawal of life-sustaining therapy in general. And so it may not be so much a donation advisor that we want to implement for pediatrics. It's a death advisor, that the impacts and timing of death and the outcomes of that dying process seem to be more emotionally triggered in the pediatric population and may help us make decisions for families and support their decisions in that context. And so I think we definitely want to go down that pathway when we're ready. I think I've probably got to go now, but I think I will put my email in the chat and happy to answer any questions along the way, if that's okay. Erica and Amal.
Yeah, perfect. So thanks everyone for the questions and comments throughout today's presentation. Dr. Dhanani, thanks on behalf of CDTRP. Thanks again for presenting. It was a very interesting topic. If anyone has additional questions, comment, or suggested topic or speakers, don't hesitate to contact Erica Croft at ecroft@cdtrp.com. Thanks again, everyone, and enjoy the rest of your day.